Welcome to this explainer. Today, we're putting on our detective hats and cracking a highly specific medical case, diagnosing and classifying hyperthyroidism. We're going to look at how doctors take a simple lab result and work their way through a branching tree of clues to find the exact culprit causing a patient's illness. It's a fascinating process of elimination, and by the end of our time today, you're going to understand exactly how this medical detective work gets done. Here is our clinical roadmap for the explainer. First, we'll define hyperthyroidism, then compare primary versus secondary, run a symptom check, crack the primary causes, and finally, look at special medical situations. Let's get right into it. Section 1. Defining hyperthyroidism, the core suspect. Before we classify anything, we gotta know exactly what we're looking for in the blood work. The absolute crucial point here is that hyperthyroidism literally means hyper T4. If you're looking at a lab chart, this means an excess of T4. It's strictly about having too much T4, and importantly, it has absolutely nothing to do with T3. Boom, we have our primary suspect. But knowing we have too much T4 doesn't actually tell us why. For that, we need to dig a little deeper. Which brings us to Section 2, primary versus secondary, scene of the crime. Now we need to figure out exactly where in the body this excess T4 is coming from. We've basically got two potential crime scenes. First up is primary hyperthyroidism, meaning the problem is right there in the thyroid gland itself. When this happens, the lab values move in opposite directions. You'll see T4 go up and TSH go down. But what if the thyroid isn't the problem? That's secondary hyperthyroidism. In this case, the issue is actually up in the brain, like a pituitary adenoma. With a secondary scenario, the lab values move in the same direction. You get an increase in T4 and an increase in TSH. To lock this into your brain, try this auditory memory trick. Think of the word centra for central brain issues. Centra matches with same direction because they both share that S sound. Centra, same, S. It's a foolproof little trick to remember that central secondary issues cause the lab markers to move together. Section 3, the symptom check, interrogating the patient. For the rest of this explainer, we're going to zero in on that first category, primary hyperthyroidism. So the lab shows high T4 and low TSH. The doctor's next move? Interrogating the patient's actual physical experience. Just because the labs show high T4 doesn't mean the patient is actually feeling it yet. If they're asymptomatic, meaning the labs are elevated but they feel perfectly fine, we classify this as subclinical. The clues are in the blood but not in their daily life. But if the patient is symptomatic and feeling the effects of that high T4, the classification flips to overt. This distinction is super important because it tells the medical detective exactly how active the disease currently is. Moving on to Section 4, cracking the primary causes, the suspect lineup. What's wild here is the sheer variety of conditions that can cause these primary overt symptoms. We know it's a thyroid problem, but what exactly is the problem? Well, here's the exact lineup of suspects an endocrinologist looks at: Graves' disease, toxic multinodular goiter, toxic adenoma, subacute thyroiditis, drug-induced thyrotoxicosis, and finally postpartum thyrotoxicosis. Literally any one of these 6 culprits could be jacking up that T4. So how do doctors sort through this? They don't guess. They use a highly logical, step-by-step diagnostic algorithm to rule out suspects one by one. To catch the right culprit, they follow a strict 3-step method. Step 1, check for pain. Step 2, if it's painless, check for antibodies in the blood. Step 3, if antibodies are negative, order a radionuclide scan. It's a pretty beautiful process of elimination, really. Let's break down how each of these steps instantly narrows down our suspect list. Step 1 is super straightforward. Is the thyroid painful? This is a massive clue. Subacute thyroiditis is the absolute only condition in our lineup that is painful. Along with the pain, labs will also show a high ESR, which is an inflammation marker. If the patient has pain and that high ESR, boom, the detective work stops right there. It's definitely subacute thyroiditis. Case closed. But what if they don't feel any pain at all? Well, if it's painless, we jump to step 2. We pivot back to the blood work to look for very specific markers. The doctor checks for antibodies, specifically the anti-TSH receptor antibody and the thyroid peroxidase antibody. If these come back positive, we've got our answer. Positive antibodies in a painless thyroid instantly crack the case. It's Graves' disease. Graves is an autoimmune condition, which is exactly why those antibodies act as the smoking gun. But hang on, what if there's no pain and those specific antibodies are negative? That brings us to our third and final diagnostic step. If the first 2 steps strike out, the doctor orders a radionuclear scan. This gives us the final visual clue, cleanly dividing our remaining suspects based on how the thyroid takes up the radionuclear material. And check out how elegant this naming convention is. If the scan shows a multinodular powder, the diagnosis is toxic multinodular goiter. Makes sense, right? The word multi is right there in both the scan result and the disease name. On the flip side, if the scan shows just a single or focal uptake with nothing around it, that single nodule indicates a toxic adenoma. By following this simple three-step tree, pain, antibodies, scan, the doctor can confidently nail down the exact cause. Which brings us to our last section. Section 5, Special Medical Situations, the alibis. Finally, we have to talk about a few special situations where a patient's recent life history provides such a strong alibi, it gives away the diagnosis instantly, letting us bypass that complex three-step scan process entirely. These life events are massive diagnostic shortcuts. For example, if a patient just had a baby and develops primary hyperthyroidism, that special situation dictates it's called postpartum thyroiditis. The recent pregnancy is the dead giveaway. Similarly, if the patient has a known history of taking specific drugs, like amiodarone, or if they recently had immunotherapy, this points directly to drug-induced thyrotoxicosis. The outside substance is the culprit. Just by taking a really thorough conversational patient history, a good medical detective spots these situations and solves the case before even ordering a scan. It's honestly amazing how logically structured medical science is when you break it down into a protocol like this. We went from a single hyper T4 lab result, figured out whether the brain or the thyroid was to blame, categorized the physical symptoms, and used pain, blood tests, and scans to find the precise cause. The next time you're looking at a medical chart or hear about a diagnosis, keep this detective playbook in mind. So if your lab results showed high T4, what story would your biological clues be telling? Thanks for joining me on this explainer, and keep exploring the incredible logic of the human body.